I won't be in. I'm going to stay here for the birthday. All right. We're going to go over the neurology clerkship exam review, and thank you, Kevin, for videoing this. And I don't know if the video will come out okay, but if it does, you guys all can stay home and chill while we are learning about neurology. Let's talk about the neurology exam. The more you guys take these exams, the better it get. You get used to the type of questions and the pace of it. The pace of it really kills students the first time they take it. By the end of the year, they usually do well. There's some basic things you guys need to know that show up year after year. One of them is the ring enhancing lesion. So you have to have in your repertoire a list of things that could be associated with the ring enhancing lesion. Almost every time, if they give you an MRI with the ring enhancing lesion, the answer to the case is in the words. You don't actually have to look at the MRI, but you have to know this differential. So demyelinating lesions could include tumefactive MS, which is one large MS lesion, glioblastoma, MET, brain abscess, tuberculosis, subacute infarction, radiation necrosis, and neurocysticercosis. Right? So these are examples of ring enhancing lesions. And really, the brain is different than every other body because you can't just stick a needle in willy-nilly and take a piece out and look under a microscope. You have to think hard about where the location is, the size and shape, and sometimes you can get the answer to what your diagnosis is just by looking at the MRI. This is CNS lymphoma, this is tuberculomas, and obviously you can't tell the difference. A neurologist can't tell you by looking at those MRIs. So you have to read the stem of the question really to get the answer. Usually if there's a glioblastoma, it'll cross the middle line, especially in an exam question. And if there's surrounding edema, there can be seizure. What you can do if you see an exam in real life, what you can do if you see a lesion and you're not sure what it is you can do a SPECT scan, see if it's hypermetabolic like a tumor might be, or if it's hypometabolic like an MS lesion or a stroke might be. Right? These are all three glioblastomas. The next thing that comes up a lot, students tell me when they take the NBME shelf exam, we don't actually see the questions, but when they tell me that there's stuff about carotid endarterectomy and stroke. And it's a moving target, and really you need to talk to the stroke doctors for the best update. But you're basically, you're balancing surgical risk and stroke risk, and there's a lot of factors that matter, plaque morphology, if they're symptomatic. If you look at up to date right now, just on endarterectomy in preparation for your neurology shelf or even your medicine shelf, if it's 70 to 90% and life expectancy is more than 5 years, the surgical risk is a factor, but you would want to fix it, and then you would consider it for asymptomatic when it's over 70%. And if you don't do an endarterectomy, then frequent monitoring is the thing you want to do. There's some benefit if you're 50 to 69%, but it's a very large number needed to treat. Vitamin deficiencies show up on the shelf exam almost every single year, and I don't know ahead of time which ones are going to be, so you just got to really have in your head all the vitamins. Thiamine can affect memory and confusion, can cause confabulation, has been associated with alcoholism. Niacin is the 3Ds, dementia, diarrhea, and dermatitis. B12 would be a really common one to show up on the exam. It's a really important thing to know about, and it can cause fatigue, memory problems, proprioceptive problems. One time there was a case on one of the NBME shelves about nitric oxide. So nitric oxide can rapidly deplete vitamin B12 stores. So if you're already B12 deficient and you send someone to the dentist to get nitric oxide, they can get permanent spinal cord damage. I want to say maybe 6 years ago that was on one of the shelf exams. If you're looking at an anemia in a patient, microcytic anemia is associated with iron deficiency, macrocytic anemia is with B12 deficiencies, B6 neuropathies, B9 fatigue. Excess vitamin A is what shows up if anything, and excess vitamin A can be one of the causes of idiopathic intracranial pressure. So in idiopathic intracranial pressure patients, you're looking for a story about an overweight, usually female, and there's some either vitamin A drug or there's another offending agent, doxycycline, tetracycline, minocycline. And in real life, you really have to go to Google because the number of offending agents is growing and growing. I don't think on a board they would ask you anything but a very classic vitamin A or a classic doxycycline patient. Vitamin D deficiency can affect bone density, depression, and autoimmune disease, including MS. So our MS patients Sometimes their story will include low vitamin D. One thing you have to know about iron deficiency is not just causing a microcytic anemia, but restless leg patients who are iron deficient, the first thing we do is replace their iron. So if you see a restless leg story, be thinking about iron levels, okay? This is the first case I want to go over with you. A 38-year-old man with double vision, reads over the last 6 months. When he reads, sometimes he has difficult swallowing, sometimes he comes to the ER after a respiratory infection, and he feels weak all over his body. What would be the first step in evaluating this patient? What do you think? So some intermittent double vision, some swallowing problem, and he just feels weak all over after a respiratory infection. What are you thinking the diagnosis is? So it could be MS. It's a relatively young person. MS patients couldn't get double vision, especially fatigue with double vision. But you see double vision or you see ptosis, you should be thinking myasthenia gravis. Swallowing is a common symptom of myasthenia gravis, and you should be looking for symmetric weakness that's fatigable weakness. It happens over and over again. So they're great when they wake up in the morning, and they're not when they go by the end of the day. They're great when they start reading and they get double vision, first blurry, then double vision the longer they read, right? Either would be a reasonable diagnosis. Where they get you in these questions, though, is they ask you the first step. And the first step in evaluating would be, ABCs and NIF. So don't be fooled. You jump to knowing the diagnosis and you're thinking, okay, how do I work up myasthenia? But really, ABCs and checking NIF and vital capacity. NIF and vital capacity tell us about if the patient needs to be intubated, how urgent it is, and you maintain the safety of the patient before you really do anything. So in this case, absolutely, ABCs would be first, NIF and vital capacity. If you're working up myasthenia gravis, then the next first step, the easiest step, is probably getting labs, acetylcholine antibody labs. And this is a good example of the medical world is changing. Right now there are 4 we call acetylcholine antibodies, binding, blocking, and modulating. And actually anti-MuSK is not an acetylcholine, but it is a myasthenia antibody, and we put it in that category. Anti-MuSK is against a muscle streptokinase mechanism. There's actually a 5th antibody that is not commercially available yet. And I don't know the name of it, and when it becomes commercially available, I'll have to know the name of it. But you guys should be aware that there's a 5th, because when you practice in 2 years, it may be that there's 5 instead of 4. And some of the antibody negative patients that have everything else about myasthenia normal, classic, they may have that 5th antibody or a 6th whenever we find it. Certainly we do EMG nerve conduction studies with rep stim to evaluate myasthenia. It's not the first or the second step. Certainly if somebody comes in with a pulmonary infection in myasthenia, we want to know, do they have a pneumonia? So we might well do a chest x-ray. And if you check deep tendon reflexes, what would you expect? In a myasthenia patient, what would you expect? They could be normal, but is it upper motor neuron or lower motor neuron? It's lower. It's a neuromuscular junction disorder. So you'd expect decreased reflexes, if anything. If this was MS, it was reasonable to think about MS here. What would you expect their reflexes to be? Hyperreflexive. And in fact, MS is an asymmetric disorder. They can have lesions in the central nervous system, and so they can have asymmetric reflexes commonly, whereas a myasthenia patient frequently has more symmetric reflexes. Symmetrically lower makes you think neuropathy, myopathy, neuromuscular junction disorder. Asymmetric upper motor neuron signs, asymmetric reflex that are brisk. You think about MS or stroke or brain tumor or something like that.
Can you have GPS that would have started, like I know we usually think of GPS as like ascending.
Yes.
Can you have leaf forms that start more in the like?
There is. There's a Miller-Fisher form that has ataxia and ophthalmoplegia, and they can describe double vision. But what they don't do is they don't have weeks and weeks of this. They don't say, well, I was fine when I started, and then as I read, I got double vision. The myasthenia patients say that. The Guillain-Barré, even the Miller-Fisher variant, say, for the last 2 days, I've been having some vision things and some ataxia. And usually Guillain-Barré, it progresses distal proximal. If it was Guillain-Barré, what would you expect the reflexes to be? Hyporeflexia. So sometimes you can't get any reflexes. Sometimes when they first come in, they're hyporeflexic, and then they go to neuro. If I gave you a STEM question and it was Guillain-Barré and I asked you the first step, what would your first step be? It still would be ABCs, NIFs, and vital capacity. So still, you stabilize the patient and you make sure that their NIFs and vital capacities don't need to be intubated. Sometimes myasthenia patients need to be intubated. Most times nowadays, we catch it before they need intubation. And so always be careful to look at what are they asking for, the first step, the next step, or the diagnostic step. Here's just the information about myasthenia gravis: fatigable weakness, ptosis, double vision. These are the acetylcholine receptor antibodies. I like to say it's like the three musketeers, right? There are three musketeers, three acetylcholine esterase or acetylcholine receptor modulators. And then the fourth one, D'Artagnan, he actually wasn't a musketeer. He joined the group later, and he was a little bit different. Sometimes I'll ask the students, actually, have you either of you read the Three Musketeers? No. Do you know what their skill was?
You said this in one of the other sessions.
Yeah. People always think that sword fighting is their skill, but actually they were musket rifle. They were sharpshooters, and they were issued musket rifles. Everybody sort of fought back in those days. We do nerve conduction studies with rep stim. We do the EMG needle portion to make sure it's not a myopathy, because muscle disorders can be symmetric weakness with low reflexes too. They don't tend to vary like myasthenia patients. They don't get worse at the end of the day. Reflexes are normal to low, and a CT scan to evaluate for residual thymus tissue with thymoma. You get better control of a myasthenia patient if you have a residual thymus tissue, if you take it out. And there's now some really non-invasive, minimally invasive ways to do that. This would never be a first step. You'd have to make the diagnosis first. We treat myasthenia patients with acetylcholine esterase inhibitors to give them more acetylcholine at their neuromuscular junction. And pyrostigmine and neostigmine are two of the most common. One of the questions that comes up on a resident exam, which is really too advanced for you guys, is that the absorption, the oral absorption of these medications is not very good. So commonly a patient with myasthenia would be on a 60 milligram tablet, say 3 times a day of pyrostigmine. If they came to your emergency room and you wanted to give them their dose, but you were concerned they couldn't swallow, and you're going to give them an IV dose, it's actually a 30-to-1 ratio. So you can't give them 60 milligrams, you can give them 2 milligrams, right? If you give them 60 milligrams, they've absorbed all of it, and they'll go into a cholinergic crisis. And the cholinergic crisis and the myasthenic crisis, there's a lot of similarities and differences. Will just confuse you on what you're supposed to be doing. So this is something in the future to be thinking about for those of you who are going to be ER docs. Make sure you have the dose translations well. Most of myasthenia is an autoimmune disease, so we use immunosuppression. And we'll use IVIG or plasma exchange, just like we do in Guillain-Barré. But long term, we use steroids and other immunosuppressing agents. Azathioprine and mycophenolate are the two most common. Here's the second question. This is a 27-year-old woman with blurry vision in her right eye only. Her left eye is fine. And it's painful when she looks around, especially it's painful when she looks around. And after checking an MRI and spinal fluid, her diagnosis was verified to be MS. So you're starting to read a question, you're thinking, oh, I know the answer. But then they give you the answer. You're like, crap, what are we going to do? So then her and her husband are thinking of getting pregnant. What's the most appropriate first treatment for an MS patient who's thinking of being pregnant? One treatment for MS is pregnancy category B. One treatment for MS has not been associated with birth defects or miscarriages and has a huge pregnancy registry. It's been around since 1997. Glitiramer, actually. Glitiramer, the GLANT are amino acids that are highly conserved in myelin. Glitiramer looks like a collection of myelin proteins. You take it subcutaneously 3 times a day. You can take it daily or 3 times a day, and it's pregnancy category B. If I had to say the most common medication questions asked on this shelf exam about MS are about glatiramer or natalizumab. Natalizumab was the first drug where we saw PML, progressive multifocal leukoencephalopathy. Glatiramer is the only drug approved for pregnancy, so the answer to this question will be glatiramer for pregnancy. Okay? Pregnancy we think is good for MS. Patients who get pregnant, in the old days before there were treatment, women with multiple pregnancies did better than women who never got pregnant before. So we really think pregnancy is good for MS. And usually while they're pregnant, while the women are pregnant, they don't get MS attacks and they don't really need to be on anything. Sometimes after their delivery, if you don't get them back on treatment, sometimes they'll have an exacerbation after. Just for your sake, the interferon beta is a treatment for MS. What do you have to know about that? Flu-like symptoms. Evaluate that liver function test can sometimes affect thyroid function. Sometimes can make depression worse. What do you have to know about teriflunomide? It's quite the opposite to glatiramer. It's pregnancy category X. So you really, really don't want to be pregnant on teriflunomide. It can increase your risk of birth defect and miscarriage. And we take active measures to prevent pregnancy in women of childbearing age who are on teriflunomide. And then finally, tell me about riluzole. Riluzole is an anti-glutamate drug. Sometimes shows up on your shelf. And what do you treat it? What do you use to treat? What do you treat with it? Riluzole, an anti-glutamate drug.
Isn't it?
There's an Alzheimer's drug.
The Alzheimer's drug is donepezil, right? It's acetylcholine esterase inhibitor in the brain, centrally. This is an anti-glutamate drug. And for a small percentage of the patients with ALS, this can extend life.
Right.
On average, if you read the literature, it extends life at 2 months. But really, it looks like there's responders and non-responders. And responders can get 2 years, 3 years out of it, and non-responders can get no extra time out of it, right? And if they get 2 or 3 years, the majority, much of that time is quality time, not neurologically devastated time. So we tried on everyone. This is an MS patient. Actually it's a T2 or flare image, and the lesions are round or oval, periventricular, perpendicular to the ventricle. The blood vessels in that region are perpendicular. You almost never see stroke near the ventricles or the corpus callosum because it's so highly vascularized. There's a lot of collateral circulation, but you see inflammatory conditions like MS. Autoimmune disease, women more than men, targets the oligodendrocyte. Low vitamin D is a risk. 2 events separated in space and time are the diagnostic criteria, and when you're doing that space and time evaluation using MRI, there's a McDonald criteria to help with that. Dr. McDonald actually was not a neurologist, he was a radiologist who was looking at ways of correlating MRI findings in the 80s and early 90s to disease processes. The spinal fluid of an MS patient, a positive spinal fluid would have elevated IgG, so compared to the serum, the index is high, the synthesis rate in the CSF is high, and there's greater than 5 oligoclonal bands that are not present in the serum, right? 85% of patients have relapsed remitting MS, 10% have primary progressive, and here are some of the medications that are available. There's actually 2 more I haven't put on yet that have just recently been approved. There's a 3rd one going to be approved in 2020. So this is another area of medicine that's growing. As you guys become practicing, you're going to have to keep up with. Let's talk about the next patient, 25-year-old with progressive ataxia and brisk reflexes. Could this person have Miller-Fisher-Guillain-Barré? She should have low reflexes. Probably not. She shows atrophy of the cerebellum and the spinal cord, and her spinal fluid is completely normal. So she has a small cerebellum. Her sister had similar syndrome when she was in her 20s as well, so there may be a congenital thing going on. And which of the following is most likely the diagnosis? So they're asking you, of the adult onset ataxias with normal fluid but small cerebellums, which syndrome is most common? It's either D or E, yes. D does not show up on your boards very often. D shows up E shows up all the time. Friedreich's ataxia is the most common adult onset ataxia. If you get an ataxia question and you're not sure, statistically you should probably pick E. It turns out of the spinocerebellar ataxias, there's more than 20 of them, right? Where you see a small cerebellum and a spine and there's syndromes around them and they run in families. Of those, Machado Joseph is the most common of those. But overall, in the whole world, Friedreich's ataxia is much more common. What do we have to know about Friedreich's ataxia? If her and her sister have it, but no parent, then one of two things. Either they're going to find out from 23andMe that her dad's not her dad, or it's recessive. And her parents each carry the recessive trait, and her and her sister have it. And actually, this is a real patient with a real MRI, and she had 4 siblings, and 2 had it and 2 didn't. And that would fit exactly in a recessive way. And you can see in a sagittal, midline sagittal film, the cerebellum's really small and atrophic, much smaller than you would expect. Smaller than you'd expect in alcoholism. But one thing, in alcoholism, you expect the mammillary bodies to be smaller. And in spinocerebellar ataxia, it's not clear that that's true. It's not clear that the mammillary bodies are affected at all. It's a frataxin gene. It's a GAA repeat disorder. And your boards and your NBME shelf love to test you on trinucleotide repeat disorders. So in your head, you should be thinking about what those conditions are. Friedreich's ataxia, Huntington's disease they commonly test on, maybe myotonic dystrophy they like to test on. That's another trinucleotide repeat. Friedreich's is a chromosome 9, and they less and less ask me to know the chromosome. When I was a student, you had to actually know the chromosome, but I haven't had any student come back and tell me you had to know the number of chromosome number. Progressive ataxia incoordination, spinal cord atrophy with damage. They don't just have incoordination of their limbs, but they have incoordination of swallowing, so they're at risk to aspirate. So if this patient came in like the Guillain-Barré or the myasthenia patient and had a pneumonia and aspirated and was having trouble breathing, the first step would be the same ABC, NIFS, and vital capacity. Make sure that they're stable. So here, a 38-year-old college professor comes to the office with incoordination and memory problems. MRI is normal. The only thing that on exam is he has difficulty with proprioception, symmetric and profound. His pupils are poorly reactive to light, and he has difficulty with short-term memory. What are you going to treat him with? So here they ask you to make a jump. You have to get the diagnosis and you have to know the treatment. Does he travel for work? This particular diagnosis, they commonly use traveling as a what do you call it? A pseudonym for what they
Buzzword.
As a buzzword, yeah. And the answer, what's the diagnosis?
Neurosyphilis.
Neurosyphilis. It could be B12 deficiency. He has proprioception, ataxia, and memory problem. B12 patients get that as well. So you have to be thinking, with this story, B12 and syphilis, but the pupils should react normally in B12. So that's your like linchpin differential. And if you were going to treat neurosyphilis, what would you treat it with?
Penicillin IV.
Penicillin IV. Yeah. Excellent. Sometimes the questions will have 2 answers that, if the alternate diagnosis was B12 deficiency, are equally good. And that gives you a clue, maybe, that that's not the right diagnosis. So excluded. Sometimes on the boards they'll show you the rash on the palms or the soles. When I was a medical student, every hand they showed you with the classic syphilis rash had a ring finger on, had a ring on the finger. And we used to joke about that. But I found one on the internet publicly, this was not my patient, that did not have a ring on it, so I thought that would be probably better. They can have normal MRIs or posterior column abnormality, proprioception's key, memory, cognitive, Argyll-Robbins. It's actually Argyll-Robertson pupil. I don't know why it says Robbins. It's a typo. And they can accommodate, but they don't react. And the treatment of choice is penicillin. And I say that actually, in a lot of ways, syphilis is better than gonorrhea because it's exquisitely sensitive to penicillin still, whereas gonorrhea has multi-drug resistance. So there's these super gonorrheas that are out there that you can't treat. And so if you're going to get something, I think you probably want syphilis. B12 deficiency looks slightly different. Normal should be 200 to 800. Actually, under 400 we treat. Proprioception is lost, they get ataxia, they get memory and cognitive problems. Classically, their cranial nerve abnormality is cranial nerve 6, but they can get any cranial nerve abnormality, and we treat with vitamin B12. And there's a whole bunch of drugs out now that can cause B12 deficiency. The proton pump inhibitors sometimes prevent good absorption of B12. Metformin, glucophage, which is a really common drug we give diabetes patients, prevents the absorption of B12. So all of my metformin patients are either low, or if I follow their B12 serially, they get lower and lower over about a 2-year period. So if you in practice see somebody with metformin, you should check their B12. I don't know if it would show up on an exam yet, but you should know about it. So a 20-year-old college student comes into the ER with the inability to look up with his right eye. His pupils do react to light, so he probably doesn't have syphilis, right? Halfway through your exam, he asks for a drink, saying that he's been so thirsty lately, and the remainder of your exam is normal. What tests would you do to confirm his diagnosis? So again, the last question, they gave you a story, they wanted you to jump from the diagnosis to the treatment. Here, I want you to go to the diagnosis to the testing. What testing does he get? He has a inability to look up. So what cranial nerve is involved? Third nerve. But his pupil's okay, so it's a pupil-sparing third nerve. And a pupil-sparing third nerve palsy is a diabetic third nerve palsy unless you're told otherwise. So you should check A1C. It could be oral glucose tolerance test, or now you can screen with A1C, right? The pupillary fibers are on the third nerve on the outside. So they're not susceptible to the ischemia of a diabetic third nerve palsy. And so this would be a classic case for a diabetic third nerve palsy, and it will resolve on its own. If the pupil's involved, it implies something's pushing on the third nerve. And on your exam, what should that be? A what? A PCOM aneurysm, absolutely. In real life, that could be a bunch of things: MS, Lyme, neurosarcoid, CNS TB, CNS lymphoma, a lot of things. But in your exam, pupil-involved third nerve palsy is a PCOM aneurysm if they offer you that answer, and a pupil-sparing third nerve palsy is a diabetic third nerve palsy. Diabetes patients actually can have any cranial nerve palsy in real life. And in real life, Lyme patients can get cranial nerve palsies, and thiamine deficiency patients usually don't, but can get a palsy, and a B12 deficiency patient can get a third nerve palsy. They usually get the 6th, but they can get a third. You would never be wrong in real life doing an MRI, but for this test, what test can confirm the diagnosis? A test of diabetes would confirm your diagnosis. I bet this guy's A1C is really high. And why is he so thirsty? Polyuria, polydipsia. Why do diabetes patients get polyuria, polydipsia? Yeah, they're losing glucose in their urine, and it's osmotically pulling water and fluid with it, which gets them dehydrated, which makes them thirsty again. This would most likely be a type 1 diabetes patient. He's 20, so he's a little older than you would expect, but it happens in 20-year-olds. It doesn't happen so much in 50-year-olds. It happens in 5-year-olds to 20-year-olds commonly. You want to know about cranial nerve abnormalities for the test. The most common ones they could test: cranial nerve 1, olfactory, either Klinefelter syndrome gets tested. I don't know why. I did have one patient with Klinefelters in 13 years. Craniopharyngioma, or some other lesion that compresses the olfactory nerve. Optic neuritis. MS is not the only thing that can give you optic neuritis. Neuromyelitis optica, even lupus can give you optic neuritis. Lyme can give you optic neuritis. Pupil-sparing third nerve palsy, diabetes. People involved is PCOM aneurysm. Cranial nerve 5, we think about VZV or HSV. When it's HSV, it's usually that one dermatome only. And cranial nerve 6, thiamine or B12. Cranial nerve 7, they'll commonly ask you about Bell's palsies and the difference between a Bell's palsy and a stroke. How can you tell the difference? So which one can raise their forehead? A stroke, because that raising of the forehead is duly innervated by both sides of the brainstem. If you have a brainstem stroke that doesn't let you raise your forehead, it's going to be a large brainstem stroke, and you won't be awake following commands, right? But if your facial nerve isn't working at all, you won't be able to raise out eyebrow, even if your spine, your brainstem is normal. So that is really what you need to know about that. And cranial nerve 8, acoustic neuroma. Hearing problem can be associated with a tumor of the acoustic nerve. Also, there's this condition, superficial siderosis, where patients slowly bleed, usually vascular leaking, and hearing loss is an early sign of superficial siderosis. 50-year-old man with progressive weakness in the proximal legs and his hand grip strength. So he has bad hand grips, weak hand grips, and his proximal legs are weak. And this is classic for one kind of syndrome. Does anybody know? Bueller? It is inclusion body myositis. So we're looking for patterns. Myopathies and myositis are symmetric. Myopathies and myositis are usually all proximal, so it's usually deltoids and hip flexors. But in this one case, it's proximal in lower extremity and distal in upper extremity. And it's progressive, and there's no treatment. They've tried a million things. They've tried steroids, it doesn't work. It's called inclusion body myositis. How would this diagnosis be made? By biopsy, yes. So you can find findings on an EMG needle exam, but it's really the biopsy that does it for you. You see these inclusion bodies on their muscle cells.
We had someone come to the ALS clinic, like they thought it was ALS.
Yes. It could easily be confused with ALS. ALS starts in one limb only and then spreads around. Inclusion body myositis starts symmetrically, and actually all 4 limbs are included very early in the course. Their hand grip they notice, and their leg weakness they notice. When we do an EMG nerve conduction study, it's to make sure that we know what muscles are involved. So we'll commonly do one on the right side or one side, and we'll do the biopsy on the other side, because we don't want to accidentally biopsy a muscle that was needled and then see inflammation from the needle spot and misinterpret it. In this case, you'll see inclusion bodies. If somebody had a mitochondrial disorder, you'll see ragged red fibers. If somebody had a myositis, like a polymyositis or dermatomyositis, you're looking for inflammation. And specifically, we don't want the needle to confuse the pathologist. So we never biopsy the side that we needled. Can you do an MRI of the thigh? You can. Sometimes you can see inflammation. You can always do it, right? CK levels, they're a little bit elevated. They're not diagnostically elevated. But if you did a CK and the CK was 5,000, then you would be leaning away from inclusion body myositis. You'd be thinking about some sort of active inflammatory myositis, right? The diagnosis would be made though by the biopsy. So again, reading the question, sometimes first step, next step, treatment. It's almost always a man. It's almost always over 50. Symmetric proximal weakness and hand weakness. What else? Progressive and no treatments available. It can be up to 10 times, CK can be up to 10 times normal, so it can be 500, but it shouldn't be 5,000. 60-year-old man with blurry vision in the right eye. His scalp is painful to the touch. This shows up on your boards and your shelf exam all the time. His CBC is normal, but his SED rate's 100. What do you think he's got? What's the appropriate next step? Start steroids. Would you do that before you do a temporal artery biopsy? Yes, you always do. Almost always when they're asking you, do you start a treatment that protects life or vision in this case, before you do the test to prove, you start ahead of time. It won't affect the biopsy that much. So these patients get long-term steroids for sometimes a year, and then you try to do a temporal artery biopsy. And in real life, they don't have to have a SED rate of 100. They can have a SED rate that's mildly elevated. In real life, the palpitation does not have to be to his temporal region. It can be anywhere in his head. The only rule in real life that has never been violated is we have never reported anywhere on earth under the age of 50. It's never happened. So if it's a STEM question to the 49-year-old, think about something else or below. If it's over 50, put this on your differential list, right? You can test Lyme if you want. You can rule out a stroke. Anyone at 60-year-old man, you probably have an obligation to rule out stroke. So you could do MRI, diffusion weighted and ADC map can tell you if there's an acute stroke, but in this case, it's sort of classic for steroids. In your head, for your boards, you should have a list of things that give you a SED rate over 100, right? TB, osteomyelitis, temporal arteritis, tumors. There may be 2 or 3 others you guys should know for your boards. That comes up. Treatment first, then testing. Where is this? Oh, this is this whole concept of treatment first, then testing. If you're suspecting HSV, do an LP and try and prove it is or isn't. And start acyclovir. It's a safe drug in the short term. If you're suspecting a brain infection, start antibiotics and then do the TAP. Don't wait till the TAP to do the antibiotics. In fact, if you can do the MRI before the TAP, so you can, once you do the TAP, you violate the meninges, your meninges may look enhancing. So if you do the MRI before the TAP, you'll make sure that there's no pressure issue for safety of doing the TAP, and you won't see that enhancement and wonder, was this because I did a TAP already or not? And the classic treatment is cefbank, and if you're thinking of listeria, you should add ampicillin. If you were thinking a gram-negative or anaerobe, if you're thinking an anaerobe CNS infection, what would you treat with? In addition to ceftriaxone, bank, and ampicillin?
On step 1.
That's a step 1 question.
He's studying for step 1.
You studying for step 1. Oh, okay. Okay, so we'll blink in. Metronidazole. And metronidazole just penetrates the CNS better than like clindamycin. So sometimes you guys learn that you use metronidazole below the diaphragm and clindo above, but metronidazole gets into the CSF better. You always do steroids before a temporal artery biopsy if you think arteritis. You always do TPA before an MRI in a stroke workup, although you do CT scan first, right? And always give thiamine before glucose if you in any way suspect thiamine deficiency or alcoholism. Okay.
Like, could you quickly clarify what the most recent guidelines are on TPA?
The most recent guidelines on
What
TPA.
what should we use for
You should use the package insert guidelines.
Okay.
And the package insert guidelines say if a person comes in and they have a stroke-like episode and their CT scan shows no bleeding, and and you can infuse the drug within an hour, and they're not getting better, and their platelets are at least 100,000, and their INR is at least 1.7, you should give TPA. If they've had the exclusion criteria, if they had a recent GI bleed, or a recent bladder bleed, or recent major surgery, you can't give it. So you can't give it to a cabbage patient whose chest wall just got sewed back up, they'll bleed into their chest wall. Exclusion criteria also is if they had a seizure at the onset of the event. Although it's probably safe, the package insert says seizure is an exclusion criteria. Then after the drug has come out, the FDA has extended the interval window to 4.5 hours for patients who are under 80, haven't had a previous stroke, and they don't have diabetes. And you have to use the guidelines to answer the questions in the exam. They would never ask you outside the guidelines. But the confusing part is when you're on service, the stroke specialists, experts, can do it off-label. They could do it for a patient whose platelets are 90,000, but you have to know 100,000 is the rule for the test. Does that make sense? In the real INR is 1.7. I don't think they would ever give you a question that says the patient's INR is 1.8. Can you give TPA or not? What they could do is they could give you a question that says the person has atrial fibrillation, they're on Coumadin, their INR is 2.8, and can you give TPA? And the answer could be no in that case, or it could be you can bring the INR down below 1.7 to, if you get it down to 1.6, you can give TPA even to an anticoagulated patient. If you're bringing the coagulation down, the INR down, you have to use fresh frozen plasma. The vitamin K takes too long. But I don't think they would ever give you a fine line like, well, if there was 98,000 platelets, would you give TPA? Because they know that that's a relative confusing thing. 26-year-old man with back pain, numbness, weakness.